Hello, this is John Kanelopoulos from our office here in Athens, Greece, the LaserVision Ambulatory Surgery Unit, Clinical Professor of Ophthalmology at NYU Medical School in New York City, New York. Very pleased to share with you quite the challenging case. This is a case with a significant cataract. During the transplantation, the penetrating keratoplasty for keratoconus, we had very positive pressure. We had iris enclaved in the wound. We were able to manage very good graft, but you can see a large area of iridodialysis around 10 o'clock. He started, the reason we resutured this penetrating graft performed elsewhere, he started with a very high cylinder, over 15 diopters, and by resuturing, we were able to reduce the cylinder to eventually under 5 diopters, and thus the resuturing. The actual graft was very good. We can see here the DALK, the deep anterior lamellar keratoplasty. That was his initial procedure that, though had astigmatism at the level that we could not approach with laser vision correction. Thus, we decided to resuture and treat the cataract surgery at a later time. So we have to deal now with a very nice complex of a DALK. As I mentioned, the astigmatism now has been reduced to 5 diopters. We can see it here, marked improvement from our resuturing. We have our actual length measurements. Since we're going to try and treat some of the residual refractive error, astigmatism, and ametropia with the choice of an IOL. And of course, we're going to plan within this procedure to address the iridodialysis at the 10 o'clock position. Per protocol, we obtained several interferometry measurements, the lens star, the Tomei interferometer, as well as the interferometry incorporated in a sitemap device, which is the Pentacam AXL wave adapted by Wavelight. And these are the placido disc topographies with 2.3 diopters of astigmatism here. And again, we'll see the topography by the Tomei. Again, the benefit of us resuturing the graft, although I may share with you, is quite challenging since we encountered very strong positive pressure, almost no chamber, and a lot of iris prolapse. The endothelial cell count is great. This is the patient's own endothelium, and these are the numbers. We decided to go with a plus 26.5 lens, so we realized this hyperopic eye with treatment for the astigmatism. This is our standard 91 degrees with the Acrosoft Toric IOL Calculator T9 lens. We always try to aim with one level lens higher since approaching the exact axis is elusive. So we know that every 2 degrees of deviation from the axis reduces the power of the toric lens by 8%. So we always like to opt one level lens stronger, toric lens stronger, since it would be almost impossible to reach the exact degrees of axis to be corrected. Our main incision at the 10 o'clock position, we're going to try and place this paracentesis at the 3 o'clock position and avoid cutting the interrupted sutures. You can see how irregular is the iris with full dilatation, so we're going to use some iris hooks. Going a little bit old school here, use several iris hooks to give us a good dilatation during the procedure in order to perform the cataract procedure initially as easy and safe as possible with good visualization. We ended up placing, as you can see here, 5 iris hooks. Of course, other alternatives here are pupil expanders such as the Malyugin ring. There's other expanders. Visitek has a great one. We could see the advantage of using the iris hooks. We have a tremendously large pupillary opening now. We're going to reform the anterior chamber with Viscoat, our go-to viscoelastic, as it provides the maximum protection for the cornea endothelium. We're going to lice some of the iris synechiae with the anterior capsule here very gently. We don't want to tear the anterior capsule using a Kugelin hook. And now with our cystotome, we're going to incise the anterior capsule and start a continuous cervilinear capsulorhexis in a standard fashion. We've converted this very challenging procedure due to the chorectopia and significant iridodialysis at the 10 o'clock position to a relatively standard cataract procedure. We have a toric IOL markings. This is performed under periorbital anesthesia. I use 5 cc's of xylocaine and 5 cc's of BSS with, of course, white ACE, and that tends to last about 1 hour. So within half hour after completion of the procedure, most patients have full movement of their eyelids and their eye and leave our surgery center with their eyes open. I find this the last years to be a golden recipe for having full cooperation of the patient in the OR. Very good chamber here in hyperopic eye. We had the history of when resuturing his graft of very strong positive pressure. So we added mannitol half hour prior to commencing here our procedure in order to decompress the vitreous cavity and have even more room and less pressure coming in from the posterior chamber. You can see I'm going very carefully here. The anterior capsule is a little bit obstructed by some iris debris, but we're nevertheless flowing very nicely. We don't have any significant synechiae. Visualization is relatively good, and we will complete our capsulorhexis here. A little extra care because I'm very anxious to complete this with an intact capsule, as I'm hoping I can use that T9 toric lens. In case the capsule ruptures, we will have to go with a sulcus lens or an iris fixated lens, which will preclude us from using a toric lens, as our go-to option is the Microsoft toric spheric, which does require, in my opinion, a complete and stable intact capsule. So we're going in with our signature phaco device, another favorite in our center and by myself. We can all appreciate that although this patient is in his 40s, his history of keratoconus, continuous use of corticosteroids, and the 2 keratoplasty procedures he has undergone, the DALK procedure, which probably included air placement in the anterior chamber. This was performed elsewhere. And our conversion of the DALK procedure to a penetrating level in many sites in order to reduce the very significant astigmatism of an otherwise very nice DALK procedure. We're completing our phaco emulsification. We're very fortunate to have intact capsule. Fishing here for a little piece of nucleus is always a dangerous endeavor, and we can see that we're almost left with no cortex. Our next step, of course, will be to place our lens. This is a highly hyperopic lens, 26.5 T9. Not sure if they're available yet in the US. I was under the impression within the US toric lenses are approved up to T7. I don't know if that's still the case. Very nice implantation and unfolding. This gentle 1-2 second time lapse that the toric or all Microsoft lenses offer you. It's still one of my favorite in clinical practice. We're removing our iris hooks, and we're left with just treating the iridodialysis with the very large pupillary second pupil opening. We're going to use a straight needle on a 10 proline suture to go in with the Kugelin hook and grasp the 2 edges of that iris tear, and then in a mechanical fashion go through the limbus, grasp with the Kugelin hook the 2 free ends. Once we cut the proline suture from the needle, so one end goes on one side. This procedure is challenging only to the effect that it needs very careful and very recognizable steps because the suture is very thin and it's very easy to get tangled, mixed up, and not throw the knots in the fashion that would be optimal. So we're fishing the other edge while I'm holding the free end of the first edge with a toothless forceps, because you can inadvertently pull that suture through. Tanoproline is not as easy to use. You can see that I pulled in part of my suture. I left this unedited to share with you some of the challenges of doing this. We threw the 3 knots, trimming the edges of the knot, and we're basically done. We're going to push the iris back. We have very nice cataract procedure. This patient with his significant keratoconus had no functional vision from this eye since his teens. So it's been 30 years that his functional vision was 2100 or worse. He will jump to a 2040 plus the first postoperative day, underlining the importance of what we're doing here and why I'm sharing this with you. A challenging cataract procedure, working through a recent DALK that does look like a penetrating keratoplasty, since we went through the host. And this is the final astigmatism on Pentacam 2.8 diopters. It will improve once we remove that tight suture we placed at the 10 o'clock. Patient 1 week later is at the 2025 uncorrected level. Nothing makes us more happy and more grateful of the work that we do. I hope you found this presentation interesting. Again, IOL calculation is challenging. We like to use Pentacam, which measures the total corneal power. This is John Canelopoulos signing out. Thanks so much.